Thank you for joining us. We are from the UCLA Hub for Health Intervention, Policy, and Practice, located at the UCLA Luskin School of Public Affairs. Studies such as the long-running multi-center AIDS cohort study have found that Black sexual minority men, BSMM, are likely to have poorer art adherence and health outcomes. Aside from individual behavioral risks and co-occurring health conditions, they face more structural barriers such as poverty and housing instability, hindered access to care and treatment services. Health system level factors like quality of care or patient-provider communication also tend to diminish engagement in care. These influences cannot be isolated from the surrounding social context, which is marked by stigma and discrimination related to race and sexual minority status, and greater exposure to violence and victimization. We therefore adopt a syndemic approach to recognizing the occurrence of synergistic epidemics involving HIV, substance use, depression, and early life adversities. In this paper, we sought to understand whether medication adherence among Black sexual minority men living with HIV is associated with these structural and psychosocial syndemics. The data come from our LINX LA intervention study, which examines the efficacy of a web-based mobile app created to improve HIV treatment outcomes among Black sexual minority men. To be eligible, participants had to be at least 18, be a person living with HIV in Los Angeles County, and identify as male, Black, and or African American, and as a sexual minority, whether that be gay, bisexual, or some other minority sexual identity. They also had to own a smartphone and provide informed consent. In all, we enrolled 124 Black sexual minority men from August 2018 to August 2019. We collected different data from LINX LA participants. Upon joining the study, they completed an online survey to establish baseline data on demographics, healthcare access and utilization, physical and mental health outcomes, and legal and social service needs. 6 months into the study, they completed a follow-up survey that looked into their stressors and experiences of stigma, discrimination, and violence. The surveys used previously validated measures of all those indicators. Over the course of the study, participants also received via text messaging a brief weekly survey assessing their ART treatment or medication adherence in the past week. We also gathered data on participants' viral load counts from medical records. Of the enrolled total, 98 participants completed the online surveys and weekly text message surveys. The first of our key predictors is a structural syndemic variable scaled from 0 to 3. This structural syndemic score represents the sum of binary variables, indicating if a participant reported 1. Poverty, 2. Criminal justice system involvement, and 3. Unstable housing. We coded a participant reporting an annual income of less than $12,000 as positive for poverty. We assigned a value of 1 for criminal justice involvement if a participant gave a positive response to a single survey item asking if he had any experience in the past 5 years of being accused of committing a crime, being arrested, being charged with a crime in court or in a hearing before a judge, or receiving a sentence or probation related to an accusation of a crime. We coded a participant positive for unstable housing if he reported being homeless or having lived in a shelter in the past year. Our next key predictor is a psychosocial syndemic variable scaled from 0 to 5. This psychosocial syndemic score tallies if a participant reported binge drinking, substance abuse, depression, experience of intimate partner violence, and experience of childhood sexual abuse. A participant scoring 8 or higher on the 10-item audit scale indicates alcohol-related problems, which we then coded as positive for binge drinking. Similarly, we coded a participant positive for substance abuse if he scored 6 or higher on the 11-item DUDIT scale, a level indicating drug-related problems. We coded a person positive for exposure to intimate partner violence if he scored 11 or higher on a 20-point 4-item scale. A person was deemed positive for depression if he scored 10 or higher on the PHQ-9. Finally, we measured childhood sexual abuse based on replies to 2 questions. Between the ages of 12 and 16, did you have any sexual experiences with an adult or someone at least 5 years older? Or, before the age of 12 years, was the person you had the sexual experience with an adult or someone at least 5 years older than you? If a participant replied in the affirmative to either one, he was coded positive for childhood sexual abuse. We took the sum of the structural syndemic and psychosocial syndemic scores to construct another predictor, the total syndemic score. The outcome variable is the number of missed daily doses in the week following enrollment into the study. We used a zero-inflated Poisson zip model to analyze if the previously cited predictor variables were associated with the number of doses missed by participants. Again, our outcome variable is a count of missed daily doses ranging from 0 to 7. A zip model assumes that a sample of individuals consists of 2 distinct groups. The first is the group whose counts, in this case from 0 to 7 missed doses within the week, are generated by a Poisson process. The other group consists of the true zeros, individuals with 0 probability of having a count higher than 0. In this case, individuals with 0 probability of ever missing a dose within the week. Among participants, 58% took their medications all 7 days, missing 0 doses. Around 12% missed their medications 1 day of the week, and 30% missed their medications 2 or more days. The mean for our outcome variable was 1.3 missed daily doses. In terms of their demographics, participants ranged in age between 18 to 67 years old. Approximately 42% reported some type of employment, whether full-time, part-time, or self-employed. About 16% of participants received a bachelor's degree or higher, and 48% had an associate's degree, post-secondary technical or vocational qualification, or some type of college credit. Around 24% completed high school or a GED, and 10% had less than a high school diploma. Turning to structural syndemic factors, we saw that 56% of our participants reported poverty, 36% reported criminal justice involvement, and 26% reported unstable housing. The following shares of participants also reported these psychosocial syndemic factors. 52% had experience of childhood sexual abuse, 17% had experience of intimate partner violence, 16% had experienced thin shrinking, 41% showed indications of substance use, and lastly, 39% showed indications of clinical depression. We first did a bivariate analysis examining the association between the number of missed doses in each predictor variable. You see these results on slide 4. Only unstable housing and the structural syndemic score were statistically significant. Unstable housing increases the number of missed doses by 68%. The mean structural syndemic score is 1.16. The results suggest that a 1-point increase in this score increases the number of missed doses by 31%. We also ran a multivariate zip model that included the 2 scores for structural syndemics and psychosocial syndemics and controlled for age, employment status, and educational attainment. The result is shown on slide 5. Of these variables, only the structural syndemic score was significant. The count model yielded an estimate suggesting that a 1-point increase in structural syndemics increases the number of missed doses by 63%. Regardless of demographics and psychosocial factors, we observed that structural syndemics were associated with treatment engagement. The majority of interventions addressing HIV medication adherence and treatment engagement focus on individual-level behaviors. This is simply no longer acceptable because racial justice efforts have exposed the negative impacts of structural racism, especially its impact on Black and African American people. To reach our ending the HIV epidemic goals requires addressing oppressive structures that negatively impact treatment adherence among Black sexual minority men living with HIV. Poverty will persist with high levels of unemployment and inadequate public benefits. The added burden from COVID-19 exacerbates poverty, unemployment, and the housing crisis. we can expect to see mass evictions, likely spurring more racialized policing and criminalization, all of which feed into a brutal cycle. Thank you for joining us. This presentation is on behalf of all the co-authors listed on this final slide, particularly Dr. Ian Holloway, Director of UCLA HIP and Associate Professor of Social Welfare at the UCLA Luskin School of Public Affairs.